webinar for our last one of the spring series before our conference in June is to really give some profile to the people who won that Cochrane Award for it's a prize that recognises successful local pilots that could be globally scaled up if they had some sort of support to do that. So Cochrane has funded this prize since its beginning in 2017, and for this iteration the submissions were related to tackling research waste relevant to COVID-19, so the dreaded COVID-19 that we've all been dealing with all this time. So let me introduce our two speakers. So we're going to hear the two presentations. So John and Jeremy Grimshaw, John Lavis and Jeremy Grimshaw were the winners of the award, and their initiative was called COVID-19 Evidence Network to Support Decision Making, and then COVID END, because we like to have an acronym, don't we, in science? So John is here on behalf of them to speak to you today, and they won the first prize. And then the second prize was won by Paula, and Paula has run this Trials Methodology Research Partnership, and she's based in Liverpool. Is that right, Paula? Yeah. And this partnership is a community of practice which draws together several networks, academic institutions and partners engaged in trials and trials methodology research to strengthen links between trialists, method researchers, clinicians, patients, the public and funders. So I'm sure she'll have lots more to tell us about that. So Paula is actually going to go first. So Paula, if I stop sharing my screen and I hand over to you, you can introduce yourself a little more clearly, and off you go.
Can you see my screen, Mary? Can you see the slides?
Yes, that's looking good. Yep.
Perfect. Thanks very much, and thank you so much for this opportunity. So I'm Paula Williamson from the University of Liverpool. I'm a professor of biostatistics by background, but really I'm a clinical trialist. And I'm going to talk a little bit about trials methodology. So what is trials methodology? So there's a lovely animated video that I wasn't going to show you. It's a short video. I won't show you now. It is on our website. But essentially, trials methodology, it's research undertaken into the methods of how we plan, design, run, analyze and report the findings of clinical trials. And we've been very fortunate in the UK. The Medical Research Council invested funds for about 10 years into 5 hubs for trials methodology research, and we formed a network, but it was somewhat insular. So in 2019, we expanded into a partnership, the TMRP. And we included in our partnership organisations who are very much responsible for delivery of a large amount of research, clinical trials research in the UK. So that's the Trial Managers Network and also the network of clinical trials units. But recognising that a lot of emphasis at the moment, and particularly over the last couple of years, is about trying to make trials more efficient, less burdensome for patients, participants and clinicians by accessing routinely collected data, so healthcare systems data. That's organised by Health Data Research UK, and we brought them into our partnership. They were delighted to collaborate with us. We're not just a UK network. We collaborate with the Trials Methodology Research Network in Ireland and also the Global Health Network. We're organised sort of by topic areas, so we have 8 working groups. You can see them on the screen. I'll mention some of the work we've done in a few of those groups shortly, the work that we did in relation to COVID-19. But we also are looking to the future, and we're very keen to support the next generation of trials methodologists through PhD training. So what can we achieve as a network, as a community of practice? Well, we think we managed to convince the Cochrane Award panel that we were producing better and more impactful research with less duplication of effort, value for money, and increased knowledge exchange. And I think this quote from Marcus Manafo, who leads the UK Reproducibility Network, it really sums up the sort of ethos of the partnership, and that is that academics are part of a community who happen to work at a particular institution. Institutional affiliation is only a part of our identity. So we sort of leave the institutional affiliation at the door and are really working together, collaborating together to try and improve the way we run trials. And having got this partnership and network and working groups already in place, we actually demonstrated agility over the last couple of years. So we had the ability to pivot our efforts to COVID-19 projects. The sort of things that we did, I'll say a little bit more in a minute. So members of our adaptive designs working group were instrumental in designing some of the platform trials that really brought forth great evidence about the treatment of COVID-19, the recovery trial, Agile, and also Heal COVID. Now, we obviously saw a huge amount, I'm sure John will talk about this, huge amount of work being published, research being undertaken rapidly and published rapidly, often as preprints. Our statistical analysis working group recognized early on that there was a need for rapid and open reviews of protocols, preprints and publications, and they organized themselves to do a fantastic job of peer review. It was obvious that we didn't know what outcomes were going to be important to measure in COVID-19 beyond mortality once people had left hospital. And so core outcome sets, which are getting agreement over standardizing the outcomes to measure in research conducted in different parts of the world, was quite a crucial piece of work that we did. And the pandemic has obviously shone a light around inclusivity in clinical trials, highlighting that several different groups may be excluded from clinical trials. And our members of our conduct working group were involved in contributing to the NIHR's Include Ethnicity framework. So adaptive designs are really helpful in situations where there is limited knowledge at a time, and increasingly it's possible to adapt the design, bringing in new treatments that are thought to potentially have benefit but need testing, but also to drop those treatments that are found not to have benefit. The challenge around adaptive design is also one of a practical nature, and we do undertake practical research as well as methodological research around how to cost and staff adaptive trials. And this is, I think, one of the things that we will take from the last couple of years going forward. So the lessons learned around how to cost and staff adaptive designs, we won't lose that and we'll take it forward. Now, one of the things that we've known about for a long time is this problem of what we call outcome reporting bias. And this is sort of captured in this quote from some work we did interviewing trialists. When I take a look at the data, I see what best advances the story. And if you include too much data, the reader doesn't get the actual important message. So sometimes you get data that is either not significant or doesn't show anything. And so we just didn't include that. So what you're seeing there is selection of the results in the outputs according to what those results were, a form of selection bias. And what the partnership has done is come together to develop guidelines for the content of what's known as referred to as a statistical analysis plan. And if people refer to the statistical analysis plan, they set one in place alongside their protocol, and then they report the results according to the statistical analysis plan, it should reduce the potential for this sort of problem of bias creeping in. So we were involved in the development of the guidance and also promoting it, particularly over the last couple of years, where the studies are being run and reported very quickly. Core outcome sets. So this is an area of interest of my own. So core outcome sets are developed in response to an issue that we recognize increasingly, that clinical trials conducted looking at the same question in different parts of the world lack consistency in the outcomes that are measured, but also do not necessarily reflect the outcomes that are thought to be most or are most important to relevant stakeholders, including patients. At the start of the pandemic, there weren't any core outcome sets obviously developed for COVID-19. work was done to rapidly address that, and ongoing work now around developing agreement around the core outcomes to measure for post-COVID or long COVID is being undertaken in collaboration with the World Health Organization. So it's been recognized that we'll be able to, when evidence is needed urgently, particularly as we've seen in the pandemic, having a core outcome set that's then used across all studies in long COVID will help us collate and compare the evidence, and I'm sure John may say more about that. I said that the experience of recruiting to trials during the pandemic has really shone a light on underrepresentation, and I'm delighted to say we've funded some work by Heidi Gardner in Aberdeen, whose work will help to identify issues and hopefully find some solutions to this problem of underrepresentation. Looking to the future, we recognise that trials methods research needs a priority agenda, just as many other areas of scientific endeavour, and that's ongoing at the moment, and it is an international exercise. We are always looking to expand. So if any of you are aware of people who are doing similar things, trials, methods, research, we would love to be in contact and get them involved. We know one of the priorities that will come after that will undoubtedly be around enabling lower carbon clinical trials. So back in 2007, Ian Roberts, who led the CRASH trial, did an assessment of greenhouse gas emissions from the CRASH trial and was able to see that, you know, the actual coordinating centre, trial related travel and distribution of trial interventions was actually contributing the vast majority towards this. We're actually working on a project funded by the NIHR, working in collaboration with ERM to sort of bring that work up to date, if you like, to look at identifying a toolkit that we can then describe the carbon footprint of trials, and then we can explore what would happen if design aspects of the trial were changed in terms of the impact on the carbon footprint. And a final shameless plug, I did warn Mary I was going to do this. If you're interested in finding out more about what we're doing to try and make trials more patient-centered, more efficient, we'd be delighted to welcome you to our international conference, which is being held in Harrogate later this year. Thank you very much for this opportunity.
Thank you, Paula. Thank you. That was lovely. So what we could do is just, if there are any questions just coming up or comments that you'd like to make just to Paula now before we listen to John, please just let me know. I don't know if you want to pop anything in the chat, or I've got various people chatting, but I haven't got a question. I thought this was an amazing presentation of acronyms that I don't know how you hold all that in your head. It's amazing. Okay, well, if there is no questions for a moment, then let's ask John to come forward. Thank you for putting your screen up, John. That's great. And if John would like to share his screen now, and then after he's spoken, we can have a chat about everything that we've heard. Okay, John, great. Off you go.
Thanks. And Mary, can you see my screen in presentation mode? Mary?
Yep, you're all good, John. Yep, we can
great.
see it.
Okay, super. It's as it was the last time. It's daunting to go after Paula. We've been very inspired by her work, and we actually have a slide that uses a sporting metaphor with a podium finish, where with the gold medal goes to the platform trials that Paula was talking about, and then we give a number of examples of how in Canada instead we went down a path of very small trials, took ages to get ethics approval for, and so on. So we hope one day to catch up to them, and I would love to see Canada listed in her list of contributing countries. I'm going to talk a bit about COVID, and then I'll just end briefly on our big legacy project in case any of you would be interested in joining forces with us on it. In the early days of the pandemic, now more than 2 years ago, we were struck by the explosion of interest in and the demand for evidence synthesis. And we were blown away by the supply of evidence syntheses. When we started to do a bit of a deeper look, we found lots of new entrants to the field, people really wanting to help out in what felt like a once in a generation global crisis. But when we looked more closely at the evidence syntheses that were being prepared, a disproportionate coverage of clinical management and public health topics, many fewer addressing health system arrangements and economic and social responses. But what was perhaps even more dismaying was the significant duplication of effort, sometimes as many as 20 evidence syntheses looking at a single drug. And there was also variable quality of syntheses. So in our review of them, 1 in 4 of them were of low quality and 1/2 of them were only medium quality. And the vast majority of the evidence syntheses were rapid syntheses, one-off, they became out of date quickly, and there were remarkably few living evidence syntheses. And our diagnosis at the time was just a very low signal to noise ratio, which created terrible problems for decision makers. So we joined forces with a number of groups around the world back in April of 2020 to form COVID-END. We brought together evidence synthesis, technology assessment, and guideline groups, and we were really focused on trying to improve coordination and reduce duplication. And we went very quickly from floating the idea to actually forming the network. You'll see an amazing group of partners, many of whom were the pillars of the evidence response in their respective countries and regions. And there was a lot of very helpful information sharing that happened across the partners. Some of the early wins in what we came to call the sprint phase, as opposed to the marathon phase, which I'll come to in a moment, were the guide to key COVID-19 evidence sources, although that was later superseded by the COVID-END inventory because we searched all those sources for people and made them available in a form that was easier to use. We also, with the leadership of David Tovey, prepared a set of resources to support researchers, especially those new entrants to the synthesis field who are considering or conducting an evidence synthesis, and later our guideline colleagues did the same for guideline developers. We worked with a number of communication experts to put together principles and resources to support evidence packaging for decision makers. We invited people from around the globe who were actively engaged in supporting COVID-19 decision making to join the COVID-END community and participate in what was a very active listserv. Our colleagues at the Africa Center for Evidence developed and maintained a living hub of COVID-19 knowledge hubs. So if you wanted to zero in on a data analytics shop in Ghana or an evidence synthesis shop in Argentina, you could use the filters to find them. And then we also collaborated with Cochrane and WHO as the Secretariat for the WHO Evidence Collaborative for COVID-19. When we came to the marathon phase, we put much more emphasis on the COVID-END inventory of evidence syntheses. Originally, we were only sharing the best evidence syntheses and particularly profiling them in our twice-a-month global spotlights. But now all of the syntheses are available in a searchable form. And you'll see the improvement in the signal to noise ratio. As of a few weeks ago, we had processed more than 13,000 syntheses and identified 652 as best based on quality of the review, recency of the search, and availability of a grade evidence profile. Unfortunately, only 96 of those syntheses are living, but the living evidence syntheses about drug treatments alone means that we have to process many fewer syntheses. We no longer even bother looking at a synthesis focused on a single drug because there are 4 exceptionally high quality living evidence syntheses looking at all drug treatments. We also maintained a monthly global horizon scanning panel to get out ahead of issues before they were identified by decision makers as being something that they needed evidence about. We had a thriving community of citizen partners who were engaged in all aspects of the work. And it's always hard to fund global networks. So we undertook a lot of service work with funding from the Canadian Institutes of Health Research in Canada, focused on our domestic evidence needs, and coordinated demand coming in from all our federal, provincial, and territorial governments, and then farmed out the work to more than 40 teams across the country, almost all of which always worked with one or more citizen partners in producing the evidence products. And they varied between ultra rapid contextualized syntheses. So here's what the evidence says that we think is applicable to Canada. It may be done in as short as 4 hours, typically 1 to 3 days, but we also maintained a stable of living evidence syntheses, like ones on vaccine effectiveness against variants, which are global public goods, can be used by anybody in the world, and by month 17 had produced 150 evidence products. But our biggest legacy is to say this was a once in a generation opportunity to innovate, a once in a generation amount of demand coming from policymakers. And we don't just need to be good at dealing with global crisis, we also need to be better using evidence in routine times. So we brought together 25 commissioners from around the world, a range of country contexts, types of decision makers, including citizens, and produced an evidence report, which was published in January, now available in 7 languages. As you'll see, our conclusions here, we advanced more, we think, in our domestic evidence support systems in these last 2 years than we had in the previous 25. We believe in 2022, we're facing a once in a generation opportunity to work with political leaders to build on the right lessons learned from jurisdictions around the world, one of which would be the importance of investing in platform trials and methodology platforms like Paula described. We're currently focused on rapid jurisdictional assessments that help us identify country by country what's working well with their evidence response and what gaps exist. And we think we need to use a rapid learning and improvement approach to really systematize or scale up what's working well and to fill the gaps. So that's the main summary of the Evidence Commission report. I'll just say some of the top line messages are every country needs an evidence support system alongside an evidence implementation system, the research system, and the innovation system. And you'll see here a bit of a description of what we mean by an evidence support system, but context specific, demand driven, focused on contextualizing the evidence for a given decision in an equity sensitive way. Another key message is evidence support systems need to rely on the combined power of local evidence, so what's been learned in my country or my province or state, and the best global evidence, what's been learned from around the world, including how it varies by groups and contexts. And one of the big innovations that really took off during COVID-19 were these living evidence syntheses that slotted in new studies based on their quality. So we have a continually evolving picture of what the entire evidence space, not just what the newest study tells us. We also learned even more about how to match the right strategies to support the use of best evidence to the right issues and context. COVID-N focused particularly on a co-production model, which is the second row in the table, producing timely, demand-driven, contextualized evidence products, which is the third row, and then maintaining the COVID-N inventory, which is an example of a one-stop evidence shop, and that's in row 4. What we're currently on, and this is where we extend the invitation to all of you, if you are passionate about how can we strengthen domestic evidence infrastructures, including in your own country, let us know. We're currently working with 20 countries to document again what's going well, what are the key gaps to fill in 2022 before COVID-19 investments come to an end. If you're passionate about enhancing and leveraging the global evidence architecture, we're currently advocating with the UN system, with the World Bank, with the producers of evidence-related global public goods, with funders, to encourage them to up their game and have a much better coordinated global evidence architecture, so then those of us operating at the country level can leverage all of those evidence-related global public goods. And our final priority is putting evidence at the center of everyday life. And this is probably a many-year, if not many-decade journey. And if any of you are aware of excellent examples of resources that try to put evidence at the center of everyday life, let us know. You'll see some examples on this slide. So that's the quick run through. A really exciting opportunity that we had with COVID-19, but we didn't want to just leave it there. We wanted to make sure that we also thought about what the future would ideally look like. So if any of you want to join forces with us, we'd be delighted to welcome you. And if you have any questions or comments, happy to hear them. So thank you again. And thank you, Mary, for letting me join you and Paula today.
Oh, you're most welcome, John. So come back in, Paula. There you go. Okay, so we have a couple of questions from the Q&A. So let's start with those. So question for John, as you were just speaking, John, and I'm not quite sure I understand the question, but hopefully you will. What is a good living MA and how to check it?
So I'm assuming MA means meta-analysis. So a good living evidence synthesis, is that right? Do you think meta-analysis? Yes, yeah. So yeah, so what we do is we use a tool called AmStar, which has 11 criteria to assess the quality of the review. Essentially, you're looking at, do they transparently report the systematic application of good practices in evidence synthesis? So did they search multiple databases, have more than one person involved in data extraction? All of the steps one would hope is in an evidence synthesis, we look to see whether those were followed. So it does mix what people did and whether they remembered to report on it, but it does allow us to fairly quickly identify the ones that are done to a high standard. As I mentioned, there were a lot of new entrants in the field, didn't know a lot about evidence syntheses. So unfortunately, many low quality evidence syntheses were produced, but there are those roughly 1 in 4 that are high quality, and then those much smaller subset of them that are high quality living evidence syntheses, sometimes updated as frequently as once a week, that are the real go-to places.
Just explain to me, just to help me out a bit, the living synthesis. Does this mean that it's actually ongoing at this moment? Yep.
So, an example would be COVID is currently supporting 3 focused on vaccine effectiveness against variants, 1 focused on adults, 1 focused on children and adolescents, and 1 focused on waning immunity. Currently, the 1 focused on adults and the 1 focused on children and adolescents have been moved from being updated every week to every 2 weeks. So in those 2 weeks, any new studies that come out that address the question are assessed for quality using an adapted risk of bias tool. And then they're slotted in alongside the others. Sometimes they change our understanding of effectiveness. Other times they're low quality studies that don't really move the needle. So it's updated every 2 weeks and maintained in that way over an extended period of time. There's also been an emergence of living guidelines, and another podium finish gold medal performance in our view goes to our Australia colleagues who since April of 2020 have maintained living guidelines about the clinical management of COVID-19, often updating their recommendations every week. So the science of living evidence has really evolved both for syntheses and for guidelines, which is very exciting. And from a decision maker perspective, great, because at any moment, if they need to know what's the current state of the evidence, they can go to the most recent update.
Gosh, okay. So let me just ask this question for Paula as well. So Paula, we have an anonymous attendee asking, how can journal editors help with the implementation of core outcome sets? Should it be part of a reporting guideline?
Music to my ears. So I had time, obviously, to read the question. So I have 5 points to make.
Okay.
Bear with me. So the first thing, I think that there's a real need to raise awareness of both the need for core outcome sets and the availability of core outcome sets. So editorials to raise awareness, because obviously for many manuscripts, by the time they get to the journal, the research is completed, and so therefore it's sort of too late to include data on the core outcomes, but it's not too late to kind of ask the authors to say something about a core outcome set if it exists. So yes, there are guidelines, both the Spirit for outcomes and Consort for outcomes extensions, both of which are due sort of imminently, and they're led from Canada, as many superb reporting guidelines are. I think there's going to be an update of Spirit and Consort generally, but the Spirit, the guideline for writing trial protocols, already refers to core outcome sets, the need to consider them if a core outcome set exists. I think that, you know, you all know better as journal editors whether reviewers will be, you know, want to raise it as an issue if they're aware of a core outcome set and it hasn't been used. Is that something that you'd like the authors to address in the discussion? There may be a very valid reason why they haven't used something. As an example of a very active set of journal editors in Obs and Gynae, the Crown Initiative, so that's over 70 journal editors. They ran an editorial across many of them several years ago, that, you know, they're trying to keep the momentum up. O&G, Obs and Gynae, is quite an active area in terms of trying to improve the development and use of core outcome sets. So finally, as something that we think is helpful, anybody can go onto the COMET website and register for alerts from the COMET database. So if you're working in a particular clinical area, you can register for an alert for anything that's newly registered around core outcome sets in that area. So you can select every area, or you'll get quite a lot of emails, or you can just register to receive something maybe about type 2 diabetes or COVID-19 or long COVID. And so we're trying to raise awareness, basically. You know, it's there in many places, but it's certainly not there enough yet.
Yeah, how do you think EASE members can help with that sort of editorial?
Okay, so I don't know how editorials necessarily work. You may have people already who you would identify. I think editorials, either written by the editors or by a high-profile clinical trialist who's already bought into the idea. I mean, it's not, you know, they're not without criticism. Not all core outcome sets are the same. Mm-hmm. Some are more feasible to implement than others. So I wouldn't, you know, it wouldn't just be a kind of, oh, here you go, this is great. It does need to be a proper editorial and a proper critique. Everything will help, I think. It may be that there's a really good high quality core outcome set in the area, and the core outcome set developer could write an editorial. That may feel a little conflicted, but
that's self-promoting. But yeah, hey ho. Okay, so I'd quite like to get some feel from you about how ever did you manage to kind of, in such a short time frame, to work with so many partners? What was the logistics of actually managing finding those partners and meeting with them and sharing information to kind of make the project work? That must have been huge.
Is that directed at me, Mary?
Either of you, because you both have the
Paula,
same.
Paula, you have a much longer track record than we do. Why don't you start and then I'll jump in.
Okay. So I think it was easier for us in some senses because we already had the basis of a network. And you know, we've had great funding. We don't have funding forever, and I think that is an issue with these sorts of things. So we'd already built trust, we've built the community. We all recognized that we had skills and expertise to bring to the situation we found ourselves in 2 years ago and still do, and a collective will to actually take our skills and apply them and try to help. I think, and John's made this comment before, you know, these networks, these infrastructures, they are really valuable, and the pandemic has absolutely shown that, demonstrated how valuable they are. They aren't funded easily. They're not a single project that will happen in 3 years. You know, they need somehow or other, you need to keep them going on more than fresh air.
Yeah, because it's,
John, you know, John's done even better than we did, because we did exist before, you know.
Yeah. It's that capacity building, isn't it? It's it, and investing in those relationships so that you're ready to go. John, what about you?
Well, ours was just a very unique moment. I think all of us can remember March and April of 2020. It just felt like the world was stopping, and there were so many committed people who had been working in this space of evidence synthesis, technology assessment, and guidelines, and suddenly felt this is an opportunity to really add value. But the field was moving so fast that there was huge value in coming together. And initially we met twice a week on Mondays and Thursdays. We immediately developed 7 working groups. They would often meet once or twice a week themselves. So there was an incredible motivation and passion for the work, and people perceived great value in being able to keep abreast of developments as everybody ratcheted up the standards, but also as we began to showcase many of the challenges that were arising with duplication and others. When we transitioned to the marathon, we started to take the pressure off people, and we started to move, first to weekly and then to every 2 weeks, and now the partners get together once a month. There was that moment where there was so much value in very, very regular touch points that people were willing to make time for it. Yeah. So it was a very particular moment, and that's why I say that, Paula and others who have created and sustained over long periods of time these networks, really deserve all of our thanks, because it's one thing to do it in a crisis where there's that motivation and incentive. It's a very different thing, I think, to do it in more peacetime, and even more importantly, to sustain it in the face of given how difficult it is to find appropriate funding for these. Yeah. It has to be a passion project. You just have to be committed to doing your part to make the world a better place.
Yeah. And were you already very kind of invested in the whole Zoom, doing everything, remotely? Because that was also such a big change for everybody, wasn't it?
Absolutely.
And in some ways, though, that I know for ease, it's been a really enabling sort of thing that happened, because suddenly we were able to talk to people where we hadn't really done that before. So yeah, I can imagine that you could get people together from far and wide much Absolutely. More readily.
Yeah, so our biggest challenge wasn't about the technology, it was just about time zones. So, how do you pick a time that can accommodate our Australia colleagues and so on? But the technological developments and the need to be using those platforms just required us to move in that direction. And then it just became so incredibly efficient. 1 hour twice a week would be like this injection of all kinds of new thinking and opportunities to reduce duplication and so on. You would hear somebody else has just done a rapid synthesis that you could build on without having to reinvent the wheel. A new artificial intelligence program had been developed to do certain pieces of the process, so you could build on those developments very, very rapidly.
Yeah, really exciting. Okay, hang on. We have one more question here from Eva. So question to both of you. Do you think that a huge amount of published material on COVID-19, of which many were later retracted, was actually counterproductive in the fight against the pandemic, or does it still have some value? Interesting question.
Paula, do you want to go?
I think it would be helpful, John, for you to go first, because obviously you will have reviewed quite a lot. I mean, let me just say first of all, so our statistical analysis working group, it was actually Darren Daly in Ireland who pulled people together to do an awful lot of peer reviewing. I mean, we all of us will do peer reviewing anyway, but this was a huge amount, but they felt it was necessary, and I think what the positive thing that's come out of that is that they have also written guidance about perhaps improving the quality of future research, or indeed ways to improve the analysis of studies that have been affected by COVID-19. So lots of useful, sort of more positive things to try and help improve research in the future. from my own sort of interest around core outcome sets, yeah, I mean, it shone a light to me on how much we need to raise awareness of core outcome sets and the need to try to get at least some standardization, even if something doesn't exist. There were groups, and one was in Australia, and the WHO did some, you know, really good work early on trying to sort of get more standardized outcomes. It's not to exclude lots of other things as well, but that work was done, but actually the subsequent work needed to then implement, to get that message out to researchers. That is the bit that is the real challenge. You know, the networks and the number of people that you need to get to, who are all, for the, you know, best of intentions, doing their research very quickly. That
she's frozen. Go on, John,
yeah,
and hopefully
sure.
she'll come back to us.
Well, a lot of the same points. You know, I think for me, it just like Paula, it just points to how important awareness raising is, because the amount of research waste was just absolutely mind-boggling. I mean, just in the space of evidence syntheses, we could have, instead of the 13,000+ reviews we've processed, let alone all the ones that we don't even bother looking at because they're single drug treatments. And as I mentioned before, we have high quality living evidence syntheses across all drug treatments. If people just had been, you know, made aware of all of this, my hope would be that it would have dramatically reduced the amount of research waste. But it's also reinforced how important it is for people to be registering their protocols. We're most focused on registering protocols for reviews, but obviously registering protocols for trials as well. Adhering to standards, again, you know, how heartbreaking. 3 out of every 4 evidence syntheses, probably all done with the best intentions to address a global pandemic, but they're of sufficiently low quality that our view is that decision makers should not read them. And then there was so much noise and very little attention to efforts to improve the signal to noise ratio. So decision makers were getting bombarded by stuff. And one of the lessons that we are trying to drive attention to is, coming out of COVID-19, decision makers need to be calling for, you know, a distributed network of people producing high quality living evidence syntheses, and they need to push back against journalists and others who are asking them about preprints and the latest study hot off the press. You know, politicians need to be able to say, I don't care about your single study. Give me a few days and this team will have slotted it in alongside all the other studies on the topic based on its quality, and we will see whether the conclusions change based on that. So my hope is we draw the right lessons from all of this. We invest in registration. We you know, make sure that people are attentive to standards. We take very seriously the importance of addressing research waste. There are many, many pieces of this that we feel there are positive lessons that can be learned, and we really want to make sure people take them up and act on them.
Oh, this is sort of leading on to the whole how distracting it was to have, as you say, the kind of the sort of mainstream media who are not necessarily science media, just suddenly so interested in the topic and just wanting often a sensational story to make their headline. And this is very distracting and very counterproductive for you, isn't it?
It is. I mean, think about how much time we all lost to hydroxychloroquine and these other red herrings. And it was just such a sad thing. And so many everyday citizens got swept up in it. And then, you know, who knows, you know, what the many factors are that have continued to what feels like a dramatic rise in misinformation. But it just feels like that problem has gotten even worse. And in COVID, you know, so much was happening. So we really need to take a long, hard look at everything that went well, and the things that are going well, like Paula's platform. We need to support them, and they need to be, you know, part of the infrastructure going forward. And then in the areas where we have big gaps, we really need to address them. And it's not just about global crises. crises. It's about getting back to all of the other everyday challenges that we face. We learned a lot in the last 2 years, and I feel really passionately we really need to act on those lessons learned in the future.
Yeah, cool. Okay, so I would like to just ask one more question. How did you go about your application to the Cochrane Award competition? Like, was that obvious? Was that really obvious that that was a channel for you to help raise awareness, or because that was obviously another job, wasn't it, on top of what you were already doing? And so how did you both come to decide that you were going to go down that route and make a bid for that award?
Paula, do you want to go?
Sure. Sorry about that.
No worries.
Complete connection, so I'll have to watch it back, John. Your response. I was aware of the competition. We actually won a prize a few years ago, actually for COMET itself, rather than the Trials Methodology Research Platform. And as a result, I became a prize, on the panel awarding the prize, which was fantastic. Honestly, it's really heartwarming to see the effort that's going into trying to reduce waste and improve research. It then felt that for our partnership, we've done great stuff. We really have, but we need to raise it to the level internationally. So we need to connect to people in Canada. We need to connect to people in Kenya, and India, and all over the world. And my experience with COMET was that Cochrane, it gives you that platform. It gets to you to give presentations such as we're today, to meet different sort of stakeholders in this big research ecosystem that you wouldn't ordinarily meet. So it just felt like the right time, combined with the fact that it is recognition to all of the people who've been doing the work. So it just felt the appropriate time. Obviously, I wasn't on the panel this year.
No, indeed. No, so one of our ex-past presidents, Joan Marsh, was on the judging panel, and she was the one who recommended that we asked you to speak, because she said, I think these are like really nice projects that should be, have awareness raised around them. So that's all really good. Okay, let me have a quick look then. So I don't think I've got any more questions from anybody. There are one or two comments in the chat of sort of links to things. So if you want to just catch hold of those before we finish, and then you'll be able to do that. But we also will have those in the recording, so that will be okay. So we're okay for time, but let me just take this opportunity to tell people a little bit about the conference that's coming up for EASE members. So let me just close a few things here, and I can share my screen again. Thank you, both of you. That's been really great. So here is our headline event. So for 2022, we're very exciting. This is our first time we're ever going to try a hybrid conference. So the last couple of years, EASE has done, well, first of all, in 2020, when the crisis of the pandemic hit so immediately, we were supposed to be going to Valencia in the June, and obviously that got canned. So we then did a one-day conference called Editing in Crisis Times, and really looked at how the pandemic had affected everybody's workflows, and as you were saying earlier, the pressure of the speed at which everything was working, and suddenly everything was just going at top speed, and trying to keep pace with it all was really difficult. And then last year we did a full conference for 3 days on the theme of sustainability and environment, which was sort of tied in with the UN SDG Publishers Compact and the whole COP26 event that happened in the autumn. So that was all really nice stuff for the last 2 years. And that gave us a lot of confidence to work with the technology and to suddenly have a much greater reach into our membership, where people who would never have come to an in-person event were able to join us for relatively little money, to just join and have the benefit of that. So we're going to carry on with that. I think lots has happened, lots has changed, and the time has come for everybody to embrace the whole hybrid exercise. So we are going to Valencia finally at the end of June, 24th to the 26th. And we're going to go right back to basics with our theme. So we've called it the manuscript journey, the editor's perspective. And we're basically looking at each stage of the manuscript's production, from when it first comes, in, it's being the manuscript editors who are helping the researchers to, pull that together and make sure it's in as good a shape as possible, looking at instructions for authors and how our journals can help authors to present their paper in the most effective way, and then looking right the way through the process. So peer review, post peer review sort of comments and how it's taken on, decision time, would it be sent back for a second review, how do you deal with things that needed to be changed or asking for extra work to be done, and so on. So it follows that whole gambit right through from one end of the process to the other, and that really encapsulates our members. So we're hoping that it's a really good opportunity to go back to basics. So the event is open. It's in the registration is open now. If you go to our website, which I can maybe ask somebody just to pop our website in the chat, www.ease.org.uk. If you go there, there's a big banner on the front about the conference, and you can pop there and see the whole program, all the speakers. So there's 9 scientific sessions. There's 25 odd speakers, so people being drawn, some people coming to Valencia, some joining us online, but it really is a kind of global look at people who have really got something to say in this category. So there's also sort of various other things that are going on around the edges of the conference. So all our regional chapters, or most of them, will be doing some kind of events linked to the theme in the week before the conference, and then we'll have some workshops in the week after, but in various things. So there we go. So you're all up to date. So may I give great thanks to John and to Paula for their presentations. As I say, we will make this now available, the recording available to all. So hopefully we can get a nice big audience for you. And we will do our best to raise some more awareness of your projects, because really they are absolutely super. You've done a fantastic job, and I'm very proud that you were both winners. It's great.
Great. Thank you very much, Mary.
Okay,
good to see you, Paula.
Thank you. And you, John. Thank you, Mary. Thanks.
Okay, thank you
Bye.
for you all.
Thanks.
Take care now.
Bye-bye.
Bye-bye.